your body try to sort it out without waking you up. Heart rate goes up, right? Just to sort it out. Still can't. After that, you need to go from deep sleep to light sleep. Because in deep sleep, you're not moving, you're stuck in position, you can't breathe. Then light sleep, you can toss and turn, you can stick your butt up, right? You can turn your head, hyperextend your neck. As long as you breathe, you go back to sleep. Still not enough, your tachycardia comes in, back breath, rise in super high muscle tone, and start moving RMMA. Your masseter starts to fire. And then with possible tooth grinding. Mind you, tooth grinding sound is only noticed in 20% of the RMMA. Meaning, doesn't mean that you don't hear it, it's not happening. Okay? So let's not go on. And once you're done with that, swallow and go back to sleep. Then you depend on how many times you need to do this.
Do they get into the REM stage 4?
Sometimes because of this, patients always go into light sleep mode and they tend not to. Right? Yep. So this is what is noticed. Increase in blood pressure and also heart rate goes up. So it's just a very strong sympathetic response. So sleep bruxism is not so, so we see it, we need to treat the airway. And to treat the airway, we need to open up the airway. And tongue is the key also.
Robert Kirsten from TechScan, motion sensor expert. Last 40 years, he's been saying, I'm just going to occlusion equilibrate with occlusion sensors to get the exact picture of where the high points are. Reduce the disocclusion time. He calls this DTR. Certified DTR practitioners can do this with the help of TechScan to create this problem for good.
I think I don't dare to comment anything about this is because I don't know anything about it. Yeah. But of course, falling back to first principle, all I can say is that is it triggering the cranial nerves and any reflex, anything. If let's say the bite does not trigger, everything is in more neutral bite position, then yeah, the muscle doesn't want to fire, don't have to react. But back to the same point, we're always dealing with the teeth, but you forget about the tongue. Yeah. If you deal with the tongue, you don't have to even bother about the teeth.
But his results, disocclusion time reduction, called DTR, which is basically the time the teeth take to disocclude.
Yeah.
If you shorten that, has there been any change? Of course, he's completely oblivious of the.
No, yeah, it is. Because one of my colleagues also, even though he's very much into this field as well, like what I explained to you before, this few hours, he does occlusal equilibration as well. And to him, once you see that he equilibrate, it's going to, okay, patient is fine also. Yeah, I think definitely, right, the muscle is deviating, right, and the teeth is in the way, is definitely triggering a lot of feedback. And I can even feel it myself too on my left side. I tried orthodontics, I failed because my 7 refused to move because my 8 is stuck in position. I can't get it more buccal. It's always too lingual. And I talked to my oral surgeon, all of them just say, I still want to be your friend. Okay, I'm not going to remove that wisdom tooth for you because it's too near the nerve. Right, so I can't get rid of the 8, my 7 is stuck. And I always get unnecessary interference. But when I'm on my orthotic, I'm totally comfortable. It's exactly the same, just not. So my teeth, my jaw goes into a position, and it doesn't have to come into contact with that stupid tooth in the wrong position at all. Yeah, my muscles are totally comfortable. And of course, with tongue, then everything is guided well. Then as much as I can, during the day, I will do my. I know I'm not enough at the back still, even though it's coming to about 8-9 years of training, I still need to do more lift. Exactly like you say, it's a freeway space. I know when I'm there, I still want to get my 1 more mm. Yeah, then I know I'm done, at least. So Gerald Simmons and also Ronald Friend highlighted this also in 2008. Yeah, you also mentioned very early. When a patient exhibits obstructive sleep apnea, mandible falls back with the tongue, triggers series of event, resulting in a reflexive attempt to increase masseter tone, bring the jaw forward, improve respiration, but creating issues. So of course, in the whole discussion, we still have all this, right, by even Julian. So we're not going to go away from the personality, anxiety, but again, like I said, your posture creates your mood. If let's say I'm always like this, yeah, of course I'll feel bad. If I'm always trying to be happy, I'm happy, right? So this is what we call the somatic and the visceral, right? So if you want to get that feeling out, it can be, yeah, you're scared and then your face turn, or you can also act it out on me, right? So you have your somatic and your visceral. It's interlinked, but it also can be influenced. So which one do you want to play along? So, and again, so a lot of things looks seemingly unrelated, but if you look at it, it's just, yeah, your body is trying to catch its breath, right? And then helping all these issues that comes through, right? So what I can say is, RMMA, although similar RM frequency that's what found in cases TMD. No one can agree on this yet. Okay, as much as I say this, there's still many that says there's a psychosocial mechanism, in it, which I'm not going to deny there is, right? So, but this is one area that I think is within my capability as a dentist to deal with. When it's psychosocial, sorry, it's not me. I can't. Right. So now, as we talk about phenotyping, the re-education and phenotype of sleep apnea also is related to this. So this paper is very interesting, right? Patrick McKeown, if you know him, is teaching all the breathing. So we can try to use breathing retraining to really get to this. But I think simply, the part I understand better is this, right? If let's say you are breathing really fast during the day, that's how we discussed 3 seconds per breath. Okay, so you're very fast, your capnic center is going to detect carbon dioxide in a very different way. You hardly have carbon dioxide. So you're still water, you're not sparkling water. Okay? Alright, so then what happens is, when you go into this apneic stage, you hold your breath. Hold your breath. The moment you come out of it, then you do hyperventilation, you go in again. So you're going to repeat this job, right? Or you're able to hold your breath. Okay, your breathing is very different rate, different depth, different capnic level of tolerance. Then suddenly now you go into apnea. As you get out of it, you catch your, and you're fine. Yeah, you can breathe. Yeah. So you need to breathe until you're able to do so. But again, if you're practicing breathing, using your whole body to breathe, using your tongue to breathe, using your tongue to open up spaces, I think you will have less breathing issues at night as well. Right? So that's how it evolves. It doesn't get so complicated through this. But science is science, right? Some things, what I say is just anecdotal. It's my view, right? In my opinion. It's not even validated. So I'm teaching with common sense. Unfortunately, it's not good enough. Right? So, and yes, we talk about non-responders in all these things. Intolerant, poor responders. So I still remember attending the TURF's training in 2017, right? Every time when they talk about non-responder, my hand would be up. No, there's still the tongue and blah blah blah, and then everyone look at me like this is a crazy guy. Like, and thankfully, my course director, Dr. Leopoldo Corrier, attended the Prague World Sleep Congress just before that, and they are just about to start talking about myofunctional therapy for sleep. Right? So throughout the whole course, thankfully at least one classmate come up to me and thank me for it. The rest look at me and think, of course I'm a crazy guy. Why am I always talking about the tongue? But now, I think if you talk about being a sleep dentist and you don't do myofunctional therapy, I don't respect you. Yeah. Right. So, nitric oxide, potential, very good stuff, right? And then all this is, we talked about it earlier already. So, last bit, maybe this one. So my colleague in Japan also did a PDF highlighting this to parents. So say, don't breathe through your mouth, breathe through your nose, with your lip closed and tongue up. And if you don't, right, you have snoring issues, you have attention span, concentration, cognitive level issue. And there's a study from the new Journal of Neuroscience, 2017, if I'm not wrong, right? Nose breathing, mouth breathing. If you nose breathe, your cognitive score and your memory score is higher compared to mouth breathing. So, and we talk about tongue tie, aneurysms, facial development. So a lot of patients do have to wake up in the middle of the night, go to the toilet, right? So if they do that, then really few things happening. If they are breathing hard, high blood pressure, heart rate goes up, high pressure, blood pressure goes up. So the kidney wants to remove some of this fluid, so vasopressin go into the kidney. Then you're breathing hard and you're pressing both ways, bladder, you're pressing stomach. So your bladder is full, then you need to go a few times. And then some of them, because of their fighting for air, so they have lower inspiratory pressure here compared to the gastro area, right? And now you have a gradient. Then you have your gastro esophageal reflux. Yeah, good. So and it can go all the way through your throat to your nose and even to your ear. Yeah, when there's gastric flow back. Right. So you need to look into that. So this is Dr. Abe who's actually created this. Yeah. So to me, I think this is still the key point. Yes.
I have to agree about breathing because I started this year to do winter breathing in minus 12 degrees. And if you don't breathe correctly, you can't manage to go down in the water without ice around you. I'm really for sure, because once you don't breathe, you panic. Actually, yeah.
Wim Hof. Yeah. So I think again, as we're trying to activate the body, you can also see some individual being able to go to the mountains with one sash and in minus don't know how many degrees, and they can still keep themselves warm by just breathing correctly.
Yes, it's amazing.
I think we need to tap into the body. You can control your heart rate easily. Slow down your breathing, your heart rate drops, right? You're all aware? Yes? Yeah. So same thing. Slow down your breathing, a lot of things happen. So the perfect pitch, or should I say frequency, like how you do your tuning for your laser, is 0.1 hertz. So it's 6 breaths per minute. That's also about 6 blink per minute that you have for your eyes. 6 breaths per minute you can for your breathing. Everything slows down, right? You go into that.
So Russian technology, this was in 1940s. Professor Buteyko introduced the Buteyko technique for asthma sufferers. Control, like you said, 6 in a minute.
Yep.
Yeah.
6 to 8. Yep. I think there's guru level. Yeah, I call it 6 to 8. So if you can do that, you'll be amazing. Yeah. So I think, like I say, the 40% is really what we can do. Right, so that's all for us to grab onto. Okay, I think that should be. Yes, sorry.
Do you do night lace? Or you don't, because you already treat the root cause, so you don't have to do that lace.
No. Actually, I did 3 cases.
No.
Yeah. And then I wrote to my, just to be sure, I wrote to my, I'm already on their blacklist. I don't want to be on the darkest list ever. Right? So I say, look, if I'll do night lace for a patient for this, right? What am I within my scope? They give me very ambiguous bait answer. It's like, you do it, if I find you doing it wrong, I will catch you, that kind of answer. So like for me, it's like, get lah. But Hui Jing is doing it a lot, and she was even lecturing. So good, somebody is doing it already. Then I will try. Okay, I come to age. I don't think I want to be right out there just to take this kind of unnecessary heat anymore. Yeah, like I say, we have a lot of dentistry to do still, right? So now I'm doing more of TMD, which is still, like I say, very comfortable. I do my sleep, but now with like I said, I just shared there's a new complaint and they just talked about it. Again, thankfully I'm cleared, but it's $6,000 versus his $160 consult, and we spend $6,000 on legal fee just to answer him. Yeah. Okay. Then it's made very clear. We are going to be the dumb ass, cannot make decision. Okay? Everything must be prescribed by the ENT, right? So if you want to do a sleep device, send the patient to the ENT. ENT will say, do you want to do surgery? No. You want to do CPAP? No. You want to see a dentist? Okay, go back and see that Dr. G again. Then I can make the device.
That's for Singapore.
That's for Singapore.
That's in the UK as well.
So why are they getting the cream of the crop, train us to be doctors and dentists, and then come in and say be the dumb ass and toe the line? I don't know. So, but that is what it is. Yeah.
In the US, they have us provide a consent form that they went and saw their sleep medicine doctor, and the patient denied getting the sleep apnea, the CPAP, and that it's okay for him to get the night lace. So similar, because if something goes wrong, then
So I think it's very clear that there's a lot of protectionism going on, and I think this is as much as we can. We learn, we try to push, but then we also need to know the rules of the games, and some of these rules are not obvious to us, so you just have to play along and try to understand what do they really want to do, right? And then of course understand the bigger picture, then you can apply some of your knowledge and science in the most appropriate way, right? And demonstrate the highest level of care and standards, right? Then you can be no wrong. It's like, it's not anything, but it's just, okay, I will still do it, trust me, right? But it's just so expensive for getting the lawyers to, and so draining to fight this kind of necessary things. Even, you know what I mean? Yeah. It's just, yeah.
you're busy enough.
Yeah, we rather spend time like this where we move things forward rather than just to explain all this to them. And yet, the truth is, the person who is making all that noise will never sit down to read through everything that you provide for them.
There are stupid people everywhere. So
Yeah.
you cannot eliminate that from the world.
Yeah,
You're familiar with Professor Mew's
Yes.
viewing technique?
of course.
Is being barred from practicing orthodontics, specialist orthodontics for the last 30 odd years. GDC has banned him from practicing orthodontics just because he was promoting something similar to enhanced facial growth. It's called mewing technique. If you type mewing technique, very famous case now in UK.
It's very hard because
So you cannot practice.
but I have to say, his method is you slowly force the tongue to go out, which is, at the end they go out, because if you don't go out, these two wings will be uncomfortable, right? So the tongue has to go out. But his way is a nature way. You know what I mean? There's a different. And then like the kids will feel, oh, I got punished. You know, the stage 4 mu.
Yeah, more like negative reinforcement or positive reinforcement, right? So you don't just say don't run. You tell them where to go, right? You want me to walk, stand, sit, or what, right? So your instruction has to be clear. So I say, look, I want your tongue to go up, not the front but the back, right? At this spot, right? Keep your lips together, and then you breathe through your nose. And if you swallow, hold that spot and swallow towards the throat. Right. Everything is very clear, naturally. No need anything in the mouth per se if you just work on that. Right. So just establish that, we can only get stronger and stronger. Yes.
Where did you buy the machine back from Japan? The one
No, it's actually a US machine.
from
Myotronics.
from Seattle.
It's from Seattle.
Do you have a
Yeah, we have that. So it's 50 odd years old. So what happened is Dr. Bernard Jenkinson, right, wanted to make dentures for edentulous patient. Then he says, where should I put the teeth? Yeah. So that's how he said, okay, since the Boeing engineers are free, let me call them. Okay. So then they came up with a box, first generation to relax the muscles in tensing, and then they track that jaw position. Yeah, where is neutral. So that is where he will build his record block, and then his MMR, and then his teeth, and then patient find it very comfortable to use it at that position, and then it translates to prosthodontics mainly, yeah, restorative prosthodontics, and then when I learned it, I applied it. When I learned it, I actually learned to do it with fixed orthodontics. So you have a stabilized position, you have to create 3 splints, cut middle, cut center, cut back. You know, then you stabilize in one position, and then you move the teeth, and then you another position, move the teeth. I look at it like, oh my god, how am I gonna do this? So I came with the idea of the tongue, and then in 2018 I went back to my training center and proposed this linguadontic way. Everybody's like, how can I do that? It's like, after I stabilize the bite for so long, the patient is okay, and suddenly you change to aligners and there's no more references, right? Everybody like, yeah. So I say, no, look, you still have the tongue, you still have the tongue, you still have the tongue. So, and it's also stemmed from the fact that, yeah, while I was doing the training, one patient came in after wearing the orthodontic, the splint, for 6 years. It broke and she was in pain again. Yeah. So she insists that my trainer make one overnight for her so that she can be relieved of pain. So for us, we are lucky in the sense that there's a live patient demonstration all of a sudden. So we measure, we stay back, saw our trainer build the device, and then the next day how he has to adjust for almost 2 to 3 hours. And some patients can be adjusting for 6 hours just to get that bite to totally have no muscle signals. Yeah. But to me it's like, I just get them there, close, and I get them to use their tongue again. Because their tongue is more accurate than me by far. Yeah. So I save my time. I save my accuracy. Not that I'm not accurate, not that I don't want to, but I know they can do better than me. Yeah, so I rely on the patient again.
So is that a similar machine to the one we were in at the meeting from the
Dr. Alessandro.
Yeah. Is that similar?
So I talked to him just not too long ago. I just went over to Milan. So for him, his machine is not to measure the position. His machine is to determine, at that position, what is your muscle firing strength. Yeah, whether it's optimal. So the most optimal position is with the tongue in the position. So we can test the body straight away. So when the bite is in neutral, you're very strong. When the tongue is in the right position, you're also very strong, compared to tongue is down. So this method, we are also looking at applying it to sports dentistry. Yeah, so we can optimize a sportsman, right, with this bite, and we can increase reaction time, strength, stability, everything. So on top of therapeutic for pain management, right? We're also looking to sports optimization. So we're looking forward to next year doing the course, and hopefully all you can attend. Yes, Prof? Yes. Mm.
You are always very welcome.
Thank you.
So there is one less that missed the last part, but next time we have one less. So we will do a picture together downstairs with the